Are you going to PS, Marlene, or
No, I'm not. All the way in Hawaii.
too far? It's
Are
the
you
pit.
going?
Yeah, I'm gonna go. I'm gonna go. It's actually
Yeah.
fall under school break for our daughter, so I think we're all gonna go.
Oh, nice.
Yeah,
Very nice. Might as well, if you're going that far, add a little extra and take advantage of it.
totally, totally. Sam, are you going as well, or
Yes, I am. Yeah, I'll be
right?
there.
All right, we'll
Mm,
have to get a Mai Tai or
yeah.
something to
Mhm.
go.
A little bit of lag while people sign on.
Oh yeah, yeah.
Give it a couple minutes.
Yeah, it's been 8 years, Marlene. It's amazing.
Tell me about it.
Sure,
Feels
it's
like it
never
was just yesterday, but then at other times it feels so long. It's like both ways.
like being a parent, I think, right? um, Amazing. Sure, it's never a dull moment for you though.
No, nor you, neither you. Look all things you've accomplished. I enjoyed reading your bio. Look at you.
Sign I'm getting old. That's all, you know. But
Yeah. Luckily, I'm only getting younger. I don't have that problem you have.
that's right. You cracked that. I love it.
Just kidding.
Sam, you two you always look young, Sam.
Okay.
Sam's recuperating. You feeling a little
Oh
bit better?
gosh. Yeah, I was just telling them how bad it was, and it is. Yes, I got the flu that everyone is
Um,
getting. Yeah, it was just worse. It was really bad, the worst ever in my life. Yeah, but
yeah.
yeah, it's just,
I'm glad you're feeling better. It's
mm,
yeah, it's everywhere. My
mm.
oldest daughter got it. It was like it knocked her out for like a week. It was rough.
Really?
Yeah, like she
Wow.
was for like 2, 3 days, and then she was just like, yeah,
Dragging.
dragging. She was like, she felt like she got hit by a truck the first couple of days, and then when she was feeling better, the first day she felt better, she's like I got hit just lightly by a truck.
That was
How
exactly
old are
my
your kids?
feeling.
Yeah.
How old are your kids, Arvin?
So 18 and 14, so senior and freshman in high school.
Ooh, you're getting the college stuff going, huh?
Yeah, we're navigating it, experiencing it, living it. So a few more weeks, and then we'll close that chapter, hopefully.
Yeah, looks like we can probably start. We have got close to 20 participants.
Okay. Is my microphone on?
Yes.
Oh, wonderful. All right. Well, welcome everybody. I am Marlene Miller, and I'm the pediatrician in chief and chair here of pediatrics. And I have the honor to be moderating this session with Dr. Arvin Garg. I will give his introduction in a second, but I just want to do just a few housekeeping things for folks. The webinar is being recorded and will be available to view from the UH Research and Education Institute website. I ask that you all please mute your microphones throughout the presentation. If you need technical assistance, please contact either the R&E team, Nicole Bollinger or Abigail Zona, who are all on the call. If you have questions, please type them in either into the Q&A or the chat, and I will be looking at them. And then after we get through the presentation, I will be moderating the discussion after that. All right, so I am thrilled to have the opportunity to introduce Dr. Arvin Garg, who is a tenured professor of pediatrics and vice chair of health equity at University of Massachusetts Chan Medical School and UMass Memorial Children's Medical Center. Dr. Garg is also the Associate Chief Quality Officer for Health Equity at the UMass Memorial Health System. He is the founding director of the Child Health Equity Center at UMass Chan and UMass Memorial Children's Medical Center and is the program director of the Child Health Equity Fellowship. He received his bachelor's degree in behavioral biology from Johns Hopkins University, his master's of public health from Boston University School of Public Health, and his medical doctorate from Boston University School of Medicine. After completing his clinical residency in pediatrics at the University of Connecticut, he worked for 2 years in a private practice in Pennsylvania. He subsequently completed a postdoctoral fellowship in general academic pediatrics at Johns Hopkins University School of Medicine, which is where Arvin and I got to know each other many years ago. Dr. Garg is the first faculty, was the first faculty position at Floating, I'm sorry, his first faculty position was at Floating Hospital for Children at Tufts Medical Center. And prior to joining UMass, he was at Boston Medical Center and Boston University School of Medicine for 10 years, where he also served as Assistant Dean for Student Affairs for 5 of those years. He's been recognized for his clinical teaching and mentorship with awards from Tufts University School of Medicine, Boston University School of Medicine, the Boston Combined Residency Program, and Massachusetts chapter of the American Academy of Pediatrics. His focus for his research is on advancing child health equity by addressing adverse social drivers of health within the delivery of pediatric care, particularly for low-income families, and he's been cited in many professional guidelines. Since 2009, he has been continuously funded by the NIH and has received extramural funding from also private foundations with over 125 publications. Dr. Garg also serves on various other national committees focused on social determinants and community health, both locally, nationally, and he's also the president-elect for the Academic Pediatric Association. Welcome, Dr. Garg. We're all interested in hearing your presentation.
Thank you, Marlene. Thank you, Dr. Miller. It's great to be here. Thanks for having me on this, I guess, snowy day in Cleveland. So we can do this by Zoom and connect through the internet. So let me share my slides. Thanks for that lovely introduction. And we're going to talk about health-related social needs screenings. That's been my research area of focus throughout my whole academic career, starting in Baltimore when I was a fellow, where I used to meet and work with Dr. Miller. And so just been kind of continuing my fellowship project for the past 20 years or so. I have nothing to disclose. So my objectives are to explain drivers of health inequity for children, to explain the challenges of health-related social needs screening, and to develop equitable ideas for addressing families' health-related social needs. And so I'm going to start with a backdrop of COVID-19. You know, COVID really kind of turned our lives upside down. Dr. Mel and I were just talking about how it's kind of like a amnesia for those 2-3 years that we have all experienced together. You know, this invisible, pesky, lethal virus, you know, really exposed the best and worst in human nature and exposed great and persistent health inequities within our society. And during COVID-19, as we face that same storm, say the same COVID-19 storm, it demonstrated that in our society, we're not all in the same boat. I've taken this analogy from Dr. David Williams, professor of public health, chair of the Department of Social Behavioral Sciences at the Harvard Chan School of Public Health. And even though we faced the same pandemic, there are great disparities in who got COVID and who died from COVID. And so just some quick data in pediatrics. So Dr. Monica Goyle did a study just at the turn of just when the pandemic hit our shores in early 2020. And she found in this testing site in the DC area that there are great socioeconomic and racial disparities in who got COVID. And that low-income children, about 40% tested positive compared to about 10% for high-income children. And so low-income children had twice the odds of testing positive. Hispanic, Latino, and Black children also had twice the odds of testing positive for COVID-19 than white children, ranging between 30 to 46% to 7%. And as we think about that storm that we're all navigating, you know, we're all in different boats, but I suggest that sturdiness of our boat, and as we think about COVID-19, but kind of blossom out to think about the storm of chronic diseases, the storm of acute illnesses, the storm of all the drivers that affect our patients' health and well-being, that sturdiness of the boat that we're in, whether we're in a rowboat or a yacht or in someplace in between, it's really tied to the social determinants or the social drivers of health. The World Health Organization defines social determinants of health as the circumstances in which people are born, grow, live, work, and age. And that these circumstances are shaped by the distribution of money, power, and resources at the global, national, and local levels. And if you look at what really drives health for our patients and families, healthcare is just a small component. It's only about 20% of what drives the health of our patients. And really, it's the social drivers of health, which contributes to 80%. And studies suggest, and some extrapolated data suggests that a main factor is socioeconomic factors, one's education, job status, income, which is tied to our physical environment and which directly or indirectly affects our health behaviors, ability to exercise and to adopt health promoting behaviors. And so within the backdrop of COVID-19, there was also this really focus on racial and social justice, and it really came under the murder of George Floyd. When it was a collective moment in time when it seems so far long ago now that we were all kind of thinking about the racial inequities, the social inequities that are persistent in our society for whatever reason in the U.S. There were many vigils that were held across medical schools, across hospitals to think about the societal injustices that minoritized families, minorities, individuals still continue to face, particularly Black Americans in this country. And it also made us reflect on that as health systems to think about what in our health systems are we doing that's perpetuating this and what can we do better. And it was really a moment in time, again, that was very, very unique for all health systems to be doing this reflection to think about what we can do better. And you can contrast it, and I'm going to try to be political, but I would just say that the environment right now is just very different than where we were in that summer of 2020, with less of a focus on promoting health equity, promoting racial justice, concerns about anti-science attacks on the work we're trying to do as scientists, as clinicians, as we move forward. But nonetheless, I think we can all agree that this is a very different environment than we were just a few years ago. And so as we think about health equity, what does that mean? It's like kind of like an umbrella term, kind of like a wastebasket term. I feel like it's just kind of thrown around. I love the Robert Wood Johnson Foundation's definition, and what they define it as is that health equity means that everyone has a fair and just opportunity to be as healthy as possible. And that this requires removing obstacles to health, such as poverty, discrimination, and their consequences, including powerlessness and lack of access to good jobs with fair pay, quality education and housing, safe environments, and healthcare. And as we think about our role in the healthcare system, as we think about our role as pediatricians, when we're seeing our patients and families, either in an outpatient setting or an inpatient setting, thinking about if we're trying to advance health equity, how do we wrap our heads around all these other social drivers that we know are affecting our children's health, but we also know there's limited time, limited resources that we all have to try to promote that as we move forward. And so really during this time, again, during the pandemic and shortly thereafter, we were really trying to do in medicine what our public health colleagues have been doing for a long time. Really trying to think about a population-based approach, a community-based approach to move more upstream, to think about what are these social drivers that we can really, really address to promote health equity. And so in that backdrop, there's this huge focus on health equity by health systems, by health policymakers. And in that backdrop, there was this push to really advance social needs screening in the healthcare system in the name of advancing health equity. And so, for example, even before the first bullet, even before the pandemic started, as part of Medicaid ACOs, accountable care organizations, managed care organizations, social needs screening policies were being adopted. So in Massachusetts, we became a Medicaid ACO in about 2015, 2016, and many health systems were required to adopt social needs screening as part of the ACO quality metrics. But in the light of the pandemic and just this past, or really last year, CMS mandated that for every adult who's hospitalized for an inpatient has to be screened for social needs. And finally, as part of the Joint Commission accreditation requirement, social needs screening is required. And so within this backdrop, there's been a huge push to screen for social needs as part of regular health care. And again, a lot of it was designed to try to address health equity is in the context of what we saw due to the pandemic, due to that moment in time where there's so much attention on health equity after the murder of George Floyd. And social needs screening has a lot of great potential. So this is from the SIREN, so Social Interventions Research and Evaluation Network, their logic model. And so there's really 4 important pathways that by screening, we can be helping patients and hopefully addressing health inequities that are persistent for racialized, minoritized, and low-income patients and families. And so the goal is to identify unmet social needs as part of healthcare. One system is to then connect patients with social services to decrease social risk and then to improve health and decrease healthcare utilization. The second is to provide more emotional support, so connecting patients with social service navigators or social service support, improving emotional support. And I'd suggest that it just increases empathy. If we are talking about things that are really important for our patients and families that are top of mind, and we show empathy and we show that we care about something that is a huge relevant part of what their day-to-day experience is, and that we know it directly connects to their children's health, even that can be a net positive. Connecting patients with outpatient healthcare services, increasing outpatient healthcare services could be another approach. And then tailoring clinical care pathways. So tailoring their care plans to improve disease self-management. The classic is a diabetes, knowing if there's some food insecurity to try to address the food insecurity piece, or making sure that they have a refrigerator for their insulin to be kept in. So things like that, some basic needs. So multiple pathways that potentially social needs screening can improve health and healthcare utilization for our patients and families. And so, in this backdrop of social needs screening, and I'm going to talk more about this, but this was my fellowship project that I started in 2004. Didn't really know the term social needs back then. And it's really kind of now become part of the healthcare system care models, not only in pediatrics, but across all ages, and not just in primary care, but also across the inpatient setting, ED setting, and many subspecialty care clinics are starting to do this as well. There's so much potential, I believe in this strongly, about moving upstream to mitigate social factors that drive health outcomes. And like I said, it's been really amazing to see the explosion of interest in this area over the years and its adoption by healthcare systems. But it's also raised some important questions for me, both research-wise, but also healthcare delivery-wise, that I think are important questions that we need to be, and challenges that we need to be mindful of. I'm going to spend a few minutes talking about this. And so the first is just thinking about what's the purpose for screening within the medical care setting, right? So when we think about it, it's really to identify an as yet undiagnosed disease in individuals without signs or symptoms. So early identification will lead to early treatment, reduce morbidity. We think about this, classically for cancer screening, right? We're trying to identify early, get the proper treatment, and reduce morbidity and mortality. But when we think about social needs screening, we're screening for social needs that patients are well aware of. Patients know whether they are employed or unemployed, whether they have enough food for their family, whether they have proper housing for their families. And the treatments are outside the medical system. So we're not making a referral, we're not giving medications, we are trying to connect them to community social service agencies and resources and public benefits that are truly outside the medical system. So, really fundamentally different than what we think about screening within the medical context. And then you think about what is the purpose of social needs screening. We talked a little bit about what the potential is, but one is just to collect data. So understand the prevalence of social risks. So, what's the food insecurity rate for your patients within the context of where you provide care to. But we also know that's highly correlated with poverty. And so is that really necessary to really get at the granular level? We could think about creating risk prediction models. We're trying to move away from race-based medicine, but we do know one's lived experiences is important, one's social environment is very important. And so potentially, if we add these social factors, we could increase the accuracy of risk prediction models for healthcare utilization or for predicting disease outcomes. And the final purpose is one that has kind of driven me in this field throughout my career, is to think about intervening to use the opportunity to address patients' and families' needs with the goal to improve healthcare outcomes, and to advance health equity. So the second challenge is, are there scalable solutions? Is there sufficient support staff to assist patients with needs? And so, that's something that can be really challenging. This is data we did in one of our studies in Boston, where we collected social risk data for patients we enrolled. These were children and families who were coming into community health centers in Boston, predominantly low income, on Medicaid. And of all the families, over 90% had at least one need. Two-thirds had, two-thirds of families had two or more needs, and almost 40% of families had three or more needs. So we think about this, right? We think about oftentimes a model where we're going to connect a patient to a community health worker or to a social to a social worker, because within a pediatric visit, it's about 18 minutes to see a patient. There's so many things we need to do. It's hard for us to make that connection, as well as we don't have typically we don't have the expertise and the knowledge of resources to do that. But in settings that are taking care of low income, impoverished families, and we know poverty is highly correlated with having unmet basic needs, it could be almost every patient and family who walks through the door who's screening positive or who has a need. And how do we scale up those solutions within the delivery of healthcare for children and families? The second is that there's just, quite frankly, an insufficient safety net. There's not enough public benefits out there. When we think about housing, Section 8 housing, cities, I'm sure Cleveland, have huge wait lists, 5, 10, 15 years. And so, when we think about screening, then this is something we wrote about in a commentary a few years ago. It's almost like a shell game in many ways. So encouraging health providers to screen for homelessness may inadvertently shift limited housing resources for the poor who are not sick to those who seek medical care due to illness. And so there's only so many limited resources. And if we are screening within the healthcare system, we may be advantaging that's the word, those patients and families who are seeking medical care versus those who aren't. And again, that may be causing an inequity that isn't just at the societal level. But we know that we know that programs help and the programs work. And during the pandemic, there was this paradoxical thing that occurred, right? That because of the pandemic, there was a huge investment in the social safety net, including the child tax credit, including eviction moratoriums, including increased SNAP benefits, just to name a few, and increased unemployment benefits as well. But typically, when you look at our country compared to other countries across the world who are similarly resourced, we see that public spending on families and children in the US is the lowest compared to comparable countries like the UK, Canada, and Australia. And again, this is despite empirical evidence that spending on the social safety net actually improves health for individuals and communities. This is a study done by Dr. Bradley and her colleagues, who found that states with a higher ratio of social to health spending have significantly better subsequent health outcomes for measures such as obesity, asthma, mortality rates for lung cancer, coronary artery disease, diabetes, et cetera. And so there is empirical evidence that investing in the social safety net, both within this country and you look at data across countries, that it improves health outcomes. And the child tax credit was a great example where it actually reduced child poverty. So it was expanded during the pandemic for 1 year. For every family less than 5 years of age, they received $3,600 per child. And for kids older, it's about $3,000. And that alone decreased the child poverty rate by almost half within that year. But because of politics, because of racial stereotypes and tropes about what people are doing with that money, low-income individuals doing that money, that wasn't enacted. And overnight, the poverty rate doubled. And so we wrote this commentary a couple years ago, and one of our quotes to talk about this is that just as health systems aim to provide evidence-based medical care, they should also advocate for evidence-based social policies that promote health and health equity. So I'm going to focus now a little bit on thinking about some of those problems and those challenges, and thinking about, despite that, how do we integrate effective, empathetic social care into the healthcare delivery for our children and families. This is one of my favorite studies from Dr. Deepak Plakshapa, who's now at Wake Forest. But when he was a fellow at CHOP, he did this study, a qualitative study, trying to understand suburban families' experiences with food insecurity screening. And he found that overall, suburban parents were overall comfortable discussing food insecurity with their pediatrician, but that parents expressed initial surprise at screening, followed by comfort discussing their unmet food needs. But they felt it was really important for pediatricians to clarify that screening was to offer support and to acknowledge parents' feeling of shame that accompany food insecurity. So as we think about this context, it's beyond just asking them the two questions on the hunger vital sign. It's really to try to provide this support for families to feel comfortable sharing this needs, and support for families when they share their needs, knowing how much shame and how much stigma there is, and how much courage it takes parents for their child to share with their pediatrician that they don't have enough food to feed their child. And so I'm going to talk a little bit about the research we've done in this space. It's called the We Care study. This was literally when I was in Baltimore. I was a general academic peds fellow when I met Dr. Miller. And, I had joined the fellowship because I wanted to be a clinical educator, I thought. I wasn't, my dad was a basic science researcher. I wasn't really into the research thing. But I was at Hopkins. I kind of had to do a research project. And I kind of struggled my first few months trying to think like what was meaningful to me and what I really wanted to do. And I was going to do something around smoking cessation counseling. And then I had kind of had this aha moment. I was in the Harriet Lane Clinic, which serves intergenerationally poor families in East Baltimore. And I was precepting residents. They were doing a great job seeing the patients, seeing the families. I really kind of focused on medical conditions. And I kind of had this moment where I was like, well, is there a way we can actually try to address these needs quickly, unmet basic needs for families that we know are top of mind, that we know are really driving children's health and development? And this is before I knew the term social determinants of health, social drivers of health. And I was lucky that my primary mentors at Hopkins, Dr. Jan Sturwent and Dr. Arlene Butts, really kind of believed in this idea, believed in this concept, even though it's kind of like an outlier and kind of out there back then. And we came up with this We Care model. And so during fellowship, we did a randomized controlled trial where we randomized continuity clinics to either the We Care intervention or to standard of care. We found the We Care intervention, which consists of a self-identification of needs, asking families, do you have a need and do you want help? And then having a resource book in each exam room to give out resource sheets, increase the discussion and referral of these adverse social determinants from about 10% to over half of the visits during their visits. I subsequently moved back home to the Boston area after fellowship. I was able to get a career development award on my third try. And we decided to do another study of the We Care model to go beyond discussion and referrals to look at whether it actually made a difference in enrollment of resources. And we're able to do a cluster randomized controlled trial in 8 health centers in the Boston area. And we found was we enrolled families from and parents from birth to 6 months, when the child was either born or within 6 months of age. And we followed this cohort of children until they turned a year of age. And so 4 clinics were randomized to receive the We Care model and 4 received standard of care. And this was really a study of efficacy. So our research assistants would enroll the patients, they would give out the screeners, and we asked the providers to give out the resource sheets and have a communication and have a conversation about the needs and how important it was for them to support them in their journey to try to get resources. And we found was that for control families, families who receive standard care at community health centers, less than 10% received a referral at that index visit. But in the We Care arm, over 70% of families received at least one referral at that well child care visit. When we followed the families till they turned a year of age under controlled conditions, we found that 39% of families enrolled in a new resource compared to 24% in the control group. And this was statistically significant. We then got further funding from the NIH to do this work under real-world conditions. We did the study in 6 health centers in the Boston area. We made it standard of care for well child care visits in the first 3 years of life. Our research team trained the staff to print out We Care screeners, provide them at all those visits. They were able to access resources through their EHR. Either there was a separate website or through Epic, they were able to put in smart phrases. This was in the 2015 to 2020, so all the community health centers pretty much changed to Epic during the time of our study. And then we collected data from the EHR, and we looked at, some implementation outcomes, but also we looked at healthcare utilization outcomes and health outcomes, looking at immunization rates and well child care visits adherence, so healthcare utilization outcomes. And so this is all dependent on EHR data, which isn't always the best. We're not always the best, don't do the best job documenting. But we found that under real conditions, We Care didn't really stick that great. So overall, only less than a third of visits had a We Care screener documented. Over 40% of We Care families did receive a resource referral at a well child care visit in the first 3 years of a child's life. But the data I showed earlier was 70% of families at that first visit under control conditions received a resource referral. But when we looked at this data even closer for implementation outcomes, what really kind of bothered me, and this was during the pandemic when we were like, let's try to take this health equity lens to this work, was that over 40% of parents who asked for help on the We Care screener did not get a referral. And this has been called double loss. And so what double loss means is that when parents disclose a social need to a pediatrician or to their physician, that's one loss. They are disclosing sensitive information that is a loss that they're sharing. But not getting help or assistance is a second loss. And what we found was, in the model that we were implementing, that oftentimes we're creating this double loss for patients and families. We also found that there was a racial inequity with double loss with We Care. One of our health centers served primarily Vietnamese population, and we found that Asian Vietnamese speaking parents, predominantly at that one health center, had higher odds for double loss. So 2/3 of the time when these parents said, I have a need, I want help with food or housing, the pediatrician, the clinic staff didn't do anything about it. And so what we found was overall, for parents who experienced this type of double loss, it was associated with lower well child care visits and lower immunization adherence ratios. So potentially there could be some real harm with healthcare utilization by causing more mistrust that we're causing for parents when we don't acknowledge that the needs that they have and don't try to help them in their journey to try to access public benefits and resources. We've been doing some qualitative work recently to try to further understand this. This is work we've been doing in the Worcester area in central Massachusetts. We're doing mixed methods, and this was just a exemplar quote from one of our Latino patients talking about double loss and its impact on trust. And I'll just read it. So, well, sometimes I think that people are already afraid. Sometimes people believe that they will fill out the form and the help won't come or they won't get help. And then sometimes people say they get tired of doing this, doing that, and not receiving support. And truthfully, help is needed. If you have at least 2 or 3 months without paying rent, you fill out a form. So I filled it out. But that form, I never saw the benefit or anything like that. I never saw the help, you know? People think they will be fooled. You feel bad. You don't believe anymore. You think that they're messing with you or that they're playing with you. So it can't be like that because everyone who fills something out is because they need it. And it's particularly important as we think about this double loss, as we think about this impact on children, because since 2020, we live in a majority minority of children. That is that children of color outnumber white children in the U.S. And this is particularly important as we think about social needs screening and how we apply a health equity lens, how we make sure that we are not creating more mistrust for our marginalized patients, historically marginalized patients. But we see that, when we look at rates of poverty and being low income, which is twice the poverty level, that Black, Latino, Indigenous children have twice the odds of being low income. So 60% of these children live in low income families compared to 28%. And these numbers have stayed pretty steady over the past few years. And when we think about income, it goes beyond income to wealth. This is data from my hometown, Boston. And this is from few years ago. And again, this hasn't really changed much. But the headline in the Boston Globe was that this was not a typo. The median net worth of Black Bostonians is $8 compared to net worth for white Bostonians, which is about $250,000. And wealth is when the unexpected happens. That's when wealth happens. When wealth can help. When someone loses a job, when you're trying to buy your first house, when an accident happens or there's a malady that occurs that you need that wealth to fill in those gaps. And that generational wealth is something that just is a huge safety net for many families, but many of our Black and Latino and Brown families do not have that. And again, as we think about social drivers of health, as we move more upstream, we have to think about a structural driver of this in the U.S., and that's structural racism. This was published in Circulation from American American Heart Association, talking about the anti-Black structural racism and its linkage to poor health, starting with the original sin of slavery in 1619. And I thought it was just a really clear encapsulation of 400 years plus of history in this one figure, talking about the impact of racism, structural racism, Jim Crow laws that has led to adverse social determinants of health, that's led to these adverse concentrated areas of poverty, higher poverty rates, lower income, lower wealth for minoritized patients, minoritized families, particularly Black Americans, and how it has a direct correlation and direct impact on the health and well-being of patients, particularly children and families that we serve. And so in this context, there's been this huge push and this huge drive to screen for social needs over the past couple of years with intent to promote health equity. By moving more upstream, we can address some of the drivers that are really pushing the health outcomes that we see, the disparate health outcomes, particularly for racial and socioeconomic inequities. And that's something that's been driving me to do this work for the past 20 years, is to really be thinking about how do we improve the lives of impoverished children, and how do we take that moment in time as our voice as pediatricians to try to make this meaningful connection to try to move upstream. But unfortunately, we found in our own studies, much to my dismay, that we were probably doing some harm or a lot of harm to some of our patients by not having our clinical staff address these needs when they do come up. And so unfortunately, these well-intentioned mandates may potentially have the impact of increasing racial and socioeconomic inequities if we don't implement this right, if we don't pay attention to going beyond just screening and to making sure that we are doing it in a kind, compassionate, empathetic manner that also is realistic and pragmatic and addresses the needs that our patients and families have. And we have to think about this. We have to think about patients and families. Do they feel comfortable sharing these needs with us? Given the historical mistrust that many of our patients have, many of our Black patients have, given the poor treatment that they've experienced or that their ancestors and relatives have experienced over time. So again, going back to the pandemic, many may remember the experience of Dr. Suzanne Moore, who was a Black physician who died of COVID-19, and she felt she was treated poorly. She felt she was being treated like a drug addict. Her complaints of pain were being downplayed by her team, and she was just prematurely discharged and came back to the hospital and passed away. Again, this is another quote that we found in some of our work. Again, thinking about that context when we are trying to do social needs screening, think about the context of this wider scope of mistreatment that many of our minorities patients have experienced in the healthcare system. So she's speaking about a discriminatory clinical experience with a medical provider. So just because we're not from the same country, or just because I don't have green eyes, but I'm a human being. She doesn't have that human quality. So she sees you like as if you're a little bug because she studied and she's in the back on the other side of where she gives the medicine. So she's better than you. That's how I felt, as if oof. She said, I'm the one in charge. I'm in charge. I'm the one who decides. I'm the one in charge here. And who are you to tell me to give you the pills? If you die, you die. If you get sick, you get sick. That's your problem. That's what I got from her. And some of the work we've done around Latino patients, they've identified some barriers to engaging social needs screening, including unsuccessful attempts to obtain social needs supports within the healthcare system, lack of Spanish language offered support services, and also encountering racism and discrimination when engaging with healthcare and social service systems. So I think just really important for us to acknowledge this and to think about this as we roll out social needs screening systems across the healthcare system. And some specific themes that came up was that previous unsuccessful attempts to obtain social supports led to skepticism that needs will be met after screening. Patients and caregivers perceive the process of obtaining social services as unattainable, holding doubt about eligibility and linguistic accessibility. The experience of racism and discrimination lead to distrust that systems have patients' best interests in mind, and that the disclosure of unmet social needs carries emotional cost, such as disappointment, frustration, and feelings of discrimination that can hinder engagement in health-related social needs screening. And so, some of the missteps that we've made in our studies, some of the harsh findings we found in our studies, and some of the qualitative work has really made us double down this important need that because we're doing social needs screening, because it's correlated to poverty, because it's correlated to limited economic opportunities, because we know it's correlated in this country with race, we really need to infuse an anti-racism lens to this work. And this is the definition that Dr. Kamara Jones uses. So that anti-racism is a work of actively identifying and eliminating racism at the individual, institutional, and structural levels, which is often perpetuated through unexamined organizational structures and norms. And her framework is that race is a social construct. So if we see any differences by race, we have to name it as racism. We have to ask how it's operating, and then we have to organize and strategize stakeholders to act. And I acknowledge that in this current anti-DI culture, it may be very difficult for us to advance this work. But to think about when we look at disparities, when we look at differences, that there's these wider forces at large that are in play that we have to account for and think about if we really want to move the needle and to really make sure we have every patient, every child, every family receive the best care possible and and get their needs addressed and be as healthy as possible throughout their life course. This was a paper, a commentary that we had published, had colleagues from CHOP, Dr. Aditya Vazan and Dr. George Amber, thinking about specifically taking that lens to social needs interventions, looking at the three levels of racism: structural, institutional, and interpersonal, and the stages of intervention development, and how we can apply that from intervention development to supporting resource connection for patients and families. When we think about the medical, the EHR, we have to be mindful of what we capture there. And so this was a study done which showed that Black patients had 2.5 times greater odds of having a negative patient descriptor in the medical record compared to white patients. This was a study done by colleagues at CHOP looking at inpatient setting. They interviewed primarily minoritized parents of hospitalized children around their thoughts on health-related social needs screening. They found that overall parents expressed support and comfort with this data being collected and recorded in the EHR, but few felt comfortable it being shared with payers. And they wanted transparency around data sharing, and that they were concerned that this data could be used to disclose or result in child welfare referrals. So overall, good support that this should be collected in the EHR, but also concern and hesitancy about how the data could be used moving forward. And so we've been thinking about, how do we mitigate some of the unintended consequences of social needs screening? And so some guiding principles is that we should ensure screening is patient and family centered. So it's really centering the family and their values and their thoughts and their values first. We need to go beyond just screening, and all the regulations really focus on screening, not the connectivity part. But we really need to integrate screening with referrals and incentivize linkages to community-based resources for patients and families. We need to integrate shared decision-making. It can't be authoritarian. We have to respect if a family doesn't want to get help with food insecurity with their physician and the clinical team. We have to respect that. There is probably a lot we don't understand, but that probably would make sense to us if we understood their lived experiences and their relatives' lived experiences with the healthcare system. We need to use a strength-based approach. We have to recognize the strengths that these families, our families, and our communities have, and how they're, navigating some of these challenging circumstances that they have. But there's also many, many strengths that they bring as well. But we got to think about co-designing social care programs with patients, staff, and community members to really make this as meaningful and as impactful as possible. Ensure staff have ongoing cultural humility and health equity training, and incentivize health systems to assist patients with social needs. And that's what I've said before. Right now, health systems are incentivized to screen, but that other part of assisting patients is not incentivized yet in health policy regulations. I think money and health policies can make a big difference. Briefly, in Massachusetts, our Executive Office of Human Health Services, again, in the wake of the pandemic, changed their funding and really prioritize health equity metrics. And you can see in fiscal year 2023, $350 million has been allocated to health equity, or was back then, and still continues right now. For UMass Memorial Health, about $25 to $30 million per year as part of this acute hospital incentive program is at risk if we don't achieve these health equity outcomes. And one of them is social needs screening, which is down here. The others are to collect race, ethnicity, language, disability, sexual orientation, gender identity data, stratify it, try to address those disparities over time, as well as doing community assessments around the hospitals that we serve the communities for. And so I've talked a lot about social needs screening. It's been, again, amazing to see the explosion of interest in this topic over the years. I started my little fellowship project 20 years ago, and even there are a few people doing this type of work back then, but now it's kind of exploded and it's been adopted now by healthcare systems across the country. I think there's a lot of opportunities to do good. There's a lot of challenges. There's a limited social safety net. We as providers have limited training in how to have these conversations and how to provide empathy in these conversations. We have to acknowledge the shame and judgment and fear that our patients' families have. And we have to acknowledge that if we do this, we have to do this right, because if we don't, we have the potential to create more mistrust. If we don't screen the fall through equitably. So I'm excited about the future, the next steps as we move forward in this field together. And so some final future directions that I would suggest is that we should apply a health equity lens to the work we're doing. I know that's challenging right now, but as we think about who does this type of screening help the most, if it has the potential, it's really those most marginalized in our society. And by definition, if we don't do this right, we're not advancing health equity. We need to elevate families' voices in shaping programs and research directions. As I mentioned before, this is really critical. It hasn't happened as much as it should. We need to think about novel research strategies to investigate the impact of social care programs. It's become kind of standard of care, so we can't really do RCTs, but we have to be thinking about novel ways to do evaluations. And we have to continue to ponder what defines success, right? Is success high screening rates? Is success connectivity to referrals? Is success connecting patients to resources? Is it success having better child health outcomes, healthcare utilization outcomes, or success, advocating for a more robust social safety net, so we can retire social needs screening in the future of what we do. So just things for us to continue to think about as we move forward. And so that I'm going to end there. Thank you very much for your time and attention, and open to any questions you have. Thanks again.
All right. Thank you, Dr. Garg. That was quite a whirlwind of history and a lot of very thought-provoking data. So I'm going to lead off, and actually the first question there is almost the same question I had. In the We Care study, particularly where you had that double injury where someone expressed a need and then wasn't referred, did you happen to do any focus groups with the providers as to why referrals didn't happen? There's so many ways that could go, from implicit biases to just the productivity pressures we have and the 10-minute visits you have, right? Of how do you do it? So I'm wondering if you tapped into that as a secondary analysis in there at all to understand why referrals weren't made.
Yeah, it's a great question. We should have done this. I think we had done this ad hoc, and then during the pandemic, it was hard to get back with them. But anecdotally, it was mostly just, and I've done this myself actually. So like I have clinic tomorrow morning, and like there's 1,000 things to do. I look at the screener and I forget to make a referral. So I think it's mostly the time pressures. I think it's just mostly we don't have like set processes, workflows in place that really mitigated it. The other thing I'll say too is like we're researchers who are coming into the community health centers to do this project. And so at that time, so there wasn't we try to get as much wine as possible. We try to, bring coffee and donuts and things, but we weren't innately part of it. So I think that was also a factor for getting buy-in as well.
Yeah. I think about sometimes, when you talk with physicians, you can almost hear the term of the moral injury, and that they know that things need to happen and there's simply not the time, right? There's oftentimes there's good intention, and then all the other pressures take over. So I think it would always just be fascinating, because particularly in pediatrics, we go into this practice to help children, right? And referrals, are part of that process. All right, there's another question. When you did this study, who was actually performing the screenings? Because, this gets at, the limited resources again, and who is actually doing what is relatively a time-consuming process and to capture all this information. So how did you do it there? How are you doing it now in your clinics?
Yeah, it's a great question. So this was 2015 and 2020. Epic was changing. So it was paper screeners at the time, given out by the front desk staff or by the medical assistants, and then they would get scanned thereafter, and the research sheets would be given out by either staff or by providers. What we do now at UMass Memorial Health, we joined the ACO about 2 years ago. We had to get screening up and running about a year ago. And so we have Epic, and so we do it through MyChart. So pre-registration, we do some texting as well, and we do some paper screeners as well in multiple languages. So kind of like throw the kitchen sink at folks with screening. We're seeing more success with MyChart, but we also know that there are linguistic disparities. We only have in English and Spanish right now, so that's exacerbating our screening rates because we're seeing language disparities in who's getting screened. And I think MyChart's a big driver for that in our system. Yeah, it's hard because we're adding one more thing to really busy and burnt out staff, right? And so it's a challenge. It's an absolute challenge.
Yeah. And I also remember whenever you turn on my chart, right? I was at Hopkins when it turned on, and here there's some demographics that have a reluctance to that kind of connectivity or simply don't have that internet access. And that it's becoming an increasingly common tool to schedule appointments, look up your labs, ask for refills. But there is a segment that has limited access to it for a whole variety of reasons. Yeah. All right, there's another question. Do you have suggestions for how health systems can increase or foster their partnerships with community organizations and social service organizations to ensure a smoother handoff during that referral process?
It's a great question. I think that's that's like a $1 million question. I think if we can solve that, we'd be in business. I think there are many challenges. I'll start with the challenges. I think the challenge one is there's a lot of mistrust between large healthcare systems and with social service agencies. And with patients in general. So we have to earn the trust of our community partners. And I think that's something that's hard for us to do. That's kind of out of our comfort zone. Uh, Two, I think communicating data and communicating information between the health system and social service agencies is hard to do with HIPAA and with other constraints and different platforms that aren't talking to one another. So I think it just makes it a little more challenging. I don't think it's impossible at all, but I think it's just a challenge that we have to be able to think through. And I think it's just then creating these true partnerships, which again has not been a strength of many healthcare systems, but I think that is still really much a great potential. So in the ACO experience in Massachusetts, we had healthcare systems who were charged with creating partnerships with community organizations. But in a city like Boston, we had multiple healthcare systems kind of competing with one another to try to make partnerships. And so we had to think about a way that community organizations can work with all healthcare systems that are serving a community of patients. That doesn't matter if they go to this hospital or that hospital. And I think that just is a policy challenge that we just have to think through a little bit more. And how do we foster that type of environment, that type of partnerships between not just one health system, but multiple with these organizations?
All right, another question. Do you have any insights on how to make screening and referral process more patient and family-centered?
It's a great question. So, a lot of I didn't go into too much in this talk, a lot of the questions that folks use across the systems and in healthcare are folks on social risks, where you're trying to make a diagnosis. You're using a hunger vital sign to tell a family that they're screened positive for food insecurity. And there's a poor correlation between that and a social need where we ask families, do you want help with food? The correlation is about 40 or 50%. And so I think the social risk data can be important for risk predictive models to understand the prevalence rate of these conditions that your patients have. But I think, we can't be authoritarian about saying you screen positive, now you have to get this referral for food. We have to have a conversation. And for me, I think it's better to do social needs as well. So at UMass Memorial Health, we're able to do both. And so we ask families, do you want help with food? They say yes. That's what triggers the next step. And so we're respecting the patient's values, respecting the patient's and trying to meet them where they are with what needs they have. It's just different mentality than with making a diagnosis of a medical condition that we feel we need to do shared decision making, of course, but we feel more emboldened, I feel, to make that referral. Here, I think we had to take a step back to be really respectful. And then I think we need to do more training with our staff and providers to be able to talk about these needs. The biggest predictor of going to medical school, being a physician, is family income. I think the second is also having physicians in your family. And so many of us don't have a lived experience of of having these unmet needs that our patients have. And so we have to think about how can we connect at a level that is something that oftentimes we're not trained to do in medical school or in residency.
All right, I know we're at time, but we got one last question, so I'm going to ask you because I think we should short. Have you found third-party platforms like Unitas to be helpful in connecting people to community resources?
Yeah, I think so. Yeah, we use Find Help, Unite Us. I think they can be very useful. Absolutely. One thing we're trying to do is automate it at UMass Memorial Health, so we're not relying on a human to give out the resource sheet or to give out that information. And so I do think those are very, very useful. And the more automated we can make that part, the better, because we realize in a busy workflow, we can't always, even myself, I'll forget to give out that information sheet or make that. So I think the more automated we can do, the better. But I think that human connection of somehow quickly having providers or staff say, this is really important. I'm really glad that you felt comfortable sharing this information with me. I know this is really important for your family and for your child's health and development. This is what we're going to do. Here's the information. Reach out to me anytime if we can be helpful. And we'll see you in 2 months for your child's next child care visit. So I think it is a key part of it, but I also think the context of how we deliver it is also another key driver as well.
Well, thank you, Dr. Garg. This has been a wonderful and very thought-provoking presentation to remind us all about some of the core things of what we're all here about, of taking care of all children and taking care of all of them equally and equitably throughout their life. So thank you. And thank you everyone that has participated. It was a very good session.
Great.
Bye, everybody.
Thanks, Ron. Bye.
Arvin.
Bye, Sam. Take care. Feel better, okay?
Thanks.
Okay.